next video, next article, which is on the results of taking a different spin, but results of early primary open reduction internal fixation for treatment of OTA 4-3 C-type pilon fractures, a cohort study. And joining us is going to be Dr. Guy, and the other author was Dr. Tim White, who was interviewed.
I'm pleased to be talking with Dr. Tim White from the Royal Infirmary of Edinburgh in Scotland. Welcome, Tim, and thank you for joining me. We'll be discussing your paper from the Journal of Orthopedic Trauma back in 2010, entitled The Results of Early Primary RAF of Treatment of OTA 43C Tibial Pilon Fractures. This is a very interesting study to me in that it went against staged management of these injuries and challenged sort of that orthopedic dogma. And I guess it sort of reincarnated early single stage management of these injuries. Can you talk a little bit about the evolution of that?
Yeah, so I was in Vancouver at the time as a fellow. I had been trained in Edinburgh, where a very similar philosophy existed, in that the standard way of treating fractures of this nature was to perform primary open reduction and internal fixation. And I guess the background of this study was directly related to that history. So, of course, as I'm sure you'll have been discussing in your journal club, there's been a pendulum of preference for treating these injuries. And so the AO group popularized early fixation, and then gradually the pendulum swung over the course of the 80s and early 90s away from primary fixation because of some terrible results recorded in a number of papers, resulting in Sirkin's key paper on the stage protocol. And that had really hit quite firmly at the time that I went out to Vancouver. And I worked for a fantastic, charismatic surgeon called Bob Meek, who had really been the father of a lot of orthopedic trauma surgery in Canada, and had gathered this fantastic group of very talented orthopedic surgeons around him. And he was just absolutely incandescent in the coffee room one day, because a whole lot of his residents had been off on a course, and they'd been taught about pilon fractures, and they'd come back and they said, Dr. Meek, you're planning on doing this primary fixation this morning, and quite frankly, that's not acceptable. It's almost negligent. We've been learning all about it on this course, and the only way to treat these is using the stage protocol. And after he'd been resuscitated a little bit, we talked about the situation, and we came up with this plan to review the cases that they had been doing over the course of the previous few years, just to demonstrate that the course of treatment that they preferred, and which I had also been used to in Edinburgh, wasn't necessarily better, it wasn't necessarily universally applicable. But the key thing was really to find out, is it an acceptable alternative? And is it truly the case now that anything other than a Sirkin stage protocol is unacceptable? So that was the background. So the genesis came over a discussion, and I was sent off into the dusty archives to look out the results of their work.
That's very interesting. So when you guys had some reasonable results from this, and this sort of information got disseminated, how was it received, or what was some of the criticisms of the paper?
So it was very controversial. It was quite fun to go along to the OTA the year after I'd been a fellow in Vancouver and present it, because there was a great deal of concern. And I think there were, as usual, when you have a paper that challenges orthodoxy, there was a variety of responses between flat out disbelief and cynicism and caution. And I think perfectly reasonably, because as we know, these injuries do have potentially dreadful results, and the Sirkin protocol had provided an opportunity for a range of orthopedic surgeons with a range of different skills in treating these type of injuries to follow one safe protocol. So I think the concerns raised were principally that on one end of the spectrum, you guys are barking mad, you shouldn't be doing this, that's clearly going to lead to disaster. In the middle, there was a sort of interest, a scientific interest in, right, sort of what type of patients are you doing it on? When can this type of acute primary surgery work? And where do we start moving along that spectrum of injury severity into an area where really that's no longer applicable and the stage protocol becomes a much safer way to proceed?
That sort of opens it up a little bit. So then how does this shape your practice now, or how did it then and how does it now? Because those are the sort of questions that are very interesting, because it is a big gray area.
Yeah, absolutely. So I came back from Vancouver. I got my staff job in Edinburgh, and we were continuing to hear this skepticism, uncertainty regarding this Vancouver paper, and there were sort of quotes that this can only possibly work within a square mile of the Vancouver General Hospital, and it doesn't work anywhere else. So I knew that we'd been doing the same thing in Edinburgh for years and years. And so I then did effectively the same paper. I went back with one of my senior residents at the time, now a fantastic research colleague, and we looked at our results doing the same thing in Edinburgh, and published it in the Bone and Joint Journal, and found almost exactly the same with 102 patients. Really just confirming, I think, not necessarily that this is one protocol for everybody, not one protocol for every patient or every surgeon, but in the right situation with the right skills, the right access to operating theatres, it can be a perfectly safe, effective, successful way of managing these injuries. So really, we've then continued with this exact same protocol in Edinburgh ever since.
So that brings up a couple issues. In terms of timing, in the initial paper, you guys talked about an early treatment window and somewhere between 24 and 48 hours. In the follow-up paper, maybe a little bit longer. What's that treatment window for you, and sort of how do you define that, or what's the decision making there?
Yeah, so I think there is definitely an early period of safety. I'm unable to pin down a number of hours for you, because I think that in addition to timing, there's also quite there's clearly a very important spectrum of severity. And with lower severity, you can get away with increased timing. So ideally, these patients are in the theatre within 24 hours. Less severe injuries, perfectly possible to operate within 48 hours. Some of them, behave, particularly if they're low energy injuries, not dissimilarly to, a bad ankle fracture, in which case the timing isn't a really significant issue, and the skin is suitable for surgery throughout the course of the next 3 or 4 days. But that, I think if you're looking to say, right, we'll maybe try this policy, how are we going to set up a new protocol for our department? I would say, to start off with, until you've got a feel for this, you need to be getting this patient into the operating theatre during the course of the next day after injury. Ideally, that's within daylight hours, so you've got the right nurses and radiographers and so on to do this expeditiously. And clearly, you've got to be in a setting where you're familiar with the surgery itself.
Are these patients that you would take after hours? Because I know in the original paper, they said that the majority, I think, were operated on within 8 hours. So is this something that you, in your practice now, take sort of overnight?
No. And even in the Vancouver paper, I think it was only 25% of patients who were taken out of hours.
Yeah.
And that was in a center and at a time where out-of-hours surgery was pursued more aggressively. And I think really since the late 90s, early 2000s, and particularly maybe since the time of this paper around 2010, the number of cases done out of hours generally in orthopedics has dropped off very substantially, hasn't it? We're much more comfortable with deferring for both closed and particularly open fractures. So in answer to your question, no, very, very rarely. It would need to be an injury that had some major degree of contamination or a significant progressive neurovascular problem to be doing out of hours.
Mm-hmm. How do patient factors play into your decision making, either concomitant injuries, comorbidities, or even social factors? Or is it more of a soft tissue assessment?
Yeah, no, I think it's very much a combination of all of those. It's a synthesis of all those elements, isn't it? Mm-hmm. So in terms of the patients, both the Vancouver paper and the subsequent Edinburgh paper really demonstrated quite clearly that the patients who do badly are those with significant medical comorbidities. And so neuropathy, diabetes, alcoholism are all significantly associated with these problems. And I guess we're far more skeptical about those now. And in my practice currently, I'm gradually moving, I think, to more primary fusion of injuries of this type. So clearly we throw in severity of injury to that as well, and severity of bony and articular injury. But where there's a patient with compromised vascularity, diabetes, particularly altered peripheral sensation, I'm much more likely to consider fusion now than a painstaking reconstruction.
Now, what would you, if you were to give the listeners sort of main take-home points from this paper, what would you highlight?
I would highlight that the primary open reduction and internal fixation of peel-on fractures is perfectly reasonable, rational, and safe in the right patients, in the right environment. And that extends into quite a substantial proportion. So in the Vancouver paper, very few were managed in a staged protocol. That was 2.5%. In Edinburgh, we had slightly more, it was 20% or more. So even if it's not working for every single patient, it would work for the majority of patients.
That's great. I think that's a great place to end. Thank you, Dr. White, for your time. It's much appreciated.
Thank you very much for your time. It's been really, really interesting. Good to speak to you.